Good afternoon. I've been doing advocacy for most of the 19 years I've been disabled by this illness, and although I tried to arrange my entire month of January so I could be with you in person today, a cold and fever has left me bedridden since Saturday, so we have to rely on technology. But that's a small example of what life with this illness is like. My perspective on this study is informed by all of my advocacy experience over the last 19 years and all the various ways that I've served. And I think that the most important thing you should keep in mind during your study is that you must be as accurate and precise as possible in order to create diagnostic criteria that are both sensitive and specific for ME/CFS. And I didn't choose these terms lightly. You know what sensitive and specific means. I chose accurate and precise because your definition must match the reality of our disease. Just like when you put a pound of flour on a scale, an accurate scale will tell you the flour weighs 1 pound. That is the standard that your definition must meet. This is an extraordinary challenge because we've endured decades of inaccuracy and imprecision in the definition and diagnosis of this disease. You're being handed a mixed bag of case definitions, 9 by my count in the last 30 years, and you should go back as far as the 1950s to read the definitions of ME. Each definition has its own description of disease, its own rationale, and its own set of limitations. And as you would expect, prevalence rates vary widely because each definition draws a different circle around or within the patient population. A further challenge is that there are no gold standard diagnostic biomarkers for the heterogeneous Fukuda population. Despite that, we are very close, and some members of the panel have been instrumental in this very important research. But the breadth and weaknesses of the case definition have been a huge obstacle to achieving this. And finally, as you're no doubt aware, there are strongly held competing views about how to define this illness or even how to frame the problem. Is this mixed bag one disease or more than one disease? You have to ask yourself that question. How are we going to describe it? How do we achieve a more homogeneous cohort? What do we call it? Who is competent to diagnose it? We don't agree on the answers to those questions because there are no easy answers. As with any controversial subject, there are also some pitfalls that could really complicate your work. First and foremost is what I'm referring to as the fatigue paradigm. Severe fatigue lasting longer than 6 months is experienced by 4 to 5% of the general population, and only half of those people have an actual diagnosis to explain that fatigue. One study of newly diagnosed MS patients found that nearly 30% had been diagnosed with severe fatigue or CFS in the 3 years prior to their MS diagnosis. Because the Fukuda definition is based on fatigue, it has been used as a wastebasket for people with unexplained fatigue, and that has consigned them to a medical purgatory when they may have more treatable conditions. It may also help to draw a comparison to chronic pain, because we research chronic pain conditions across diseases in order to uncover common mechanisms and effective treatments. But we do not diagnose and define them that way. We do not diagnose fibromyalgia, vulvodynia, and migraine as one chronic pain syndrome that is subtyped based on where the pain appears in the body. We don't do that because chronic pain is too common in the general population, and it is a symptom shared by too many diseases. It's impossible for that to form the basis of an accurate and precise case definition. And I believe the same is true for severe fatigue, no matter how you try to slice it into subtypes. Second, as others have noted, and I know Charmian referred to in her talk, it's imperative to recognize the effect of case definition on research results and also the effect of the exclusionary conditions used in research. If you don't take that into account in your analysis, you won't be able to sort through the results with any resulting clarity. And third, as Gabby, Lori, and Pat have all said, this definition is not just going to go as far as the clinic and a primary care doctor. This is going to impact research, clinical trials, policy, and ultimately clinical care for everyone with this disease. So the stakes are very, very high, and that is why the controversy is so high. But I think there's a solution. There's a way for you to create diagnostic criteria that is both sensitive and specific for ME/CFS by being as accurate and precise as possible. First, start by setting aside the fatigue umbrella, because as I said, it simply cannot be the basis of an accurate and precise case definition. Instead, focus on the core symptoms of this disease. The last 30 years shows that using fatigue results in a lack of specificity at least, if not a lack of sensitivity. But across multiple studies and surveys, post-exertional malaise has been identified as the key and most disabling feature of this disease. PEM, as you've already heard, is an exacerbation of multiple symptoms after mental or physical activity. And most importantly, it can be measured through both self-report instruments and through objective biological tests. It's also very notable because it is useful in distinguishing people with ME/CFS from people who have major depressive disorder or other diseases that have a severe fatigue component. This is one of the reasons why, I think Dr. Lee alluded to this question, this is one of the reasons why advocates support Canadian, the CCC, or the ICC, because PEM has been placed front and center as the proper foundation for the diagnostic criteria. You've heard from Dr. Unger's presentation and from Dr. Egger's presentation, other features that rise to the top are cognitive impairment, especially memory and concentration difficulties. And then unrefreshing sleep and autonomic symptoms also rise to the top. There are many, many other symptoms as has been identified both in the research and in some of the surveys that you'll see, but your criteria will be more successful and more accurate if you focus on the core features shared by most patients. Another strategy that I think will help you succeed is using frequency and severity threshold cutoffs for those symptoms instead of just a checklist. A recent study found that 34% of healthy controls reported the occurrence of at least 4 out of 8 secondary Fukuda symptoms. 34% of healthy controls had at least 4 of those symptoms. But when higher cutoff thresholds for frequency and severity were used, that number dropped to 5%. So using those cutoffs is going to be critical to having a definition that is specific, that correctly excludes people who do not actually have the disease. And if you can combine that with the right core symptom set, now we're really on the road to something that's accurate, sensitive, and specific. And finally, while precision is the most important tool at your disposal, it's not going to remove all ambiguity and uncertainty because we're still in early days of understanding this disease. We don't have the longitudinal studies. We don't have the natural history studies to tell us in detail how many people with this disease change over time and what the progression of the disease is. 300 years ago, cancer could only be diagnosed when it advanced to the point of externally palpable tumors. And it was only through centuries of research that we developed the more sophisticated methods of imaging, genomic testing, subtyping, where now we can detect it early in more people and even differentiate this tumor from that tumor within a certain kind of cancer. Your case definition is part of an iterative process like all case definitions. For most definitions recently, the trend has been to broaden them, such as the diagnostic criteria for Alzheimer's disease. But that's only happened after decades of research nailed down the biomarkers, nailed down the signs of progression, so that they could be applied to a broader population and detect earlier stages. We're not there yet. And so precision and narrowing is where we have to start, with a disease that accurately reflects, or definition that accurately reflects the disease that we have. I've submitted more details in writing, including all of the references that I relied on, as have many of the other advocates. And I hope you'll review that material with the same attention that you've given us this afternoon. If I can answer any questions or assist you, my email address is on the slide, jspotila@yahoo.com. Patients represent an incredible and essential resource for your study, and you should involve us to the fullest extent. Thank you for the opportunity to speak to you today.
Thank you so much for taking the time to speak with us. We do wish you had been able to be here in person, but frankly, your comments were I think were very helpful to all of us. So thank you very much
Thank you
for taking the time.